Good morning, I'm Andrew Armstrong, Professor of Medicine at Duke University, and I'm a medical oncologist. Thursday at the GU Symposium, I presented the ARCHES trial, which is a phase 3 clinical trial. It was a global study of men with metastatic hormone-sensitive prostate cancer. Currently, men with mHSPC, as we term this, have a fairly short time to progression on androgen deprivation therapy alone. And the standard of care has evolved over the last few years to integrate docetaxel chemotherapy early in the management, abiraterone, as well as radiation to the primary site. Enzalutamide was studied in the ARCHES trial, 1,150 men in this global trial that was conducted largely after docetaxel became available and before abiraterone became available. And it's testing whether the early use of a very potent AR inhibitor could extend radiographic progression-free survival, overall survival, delay castration resistance, delay pain progression, and improve quality of life in these men. It was a positive study, and radiographic progression-free survival is a very clinically meaningful endpoint. And so this is the amount of time that a man has until his disease gets worse on imaging, such as bone scans, soft tissue, visceral sites, or death. And this trial met its primary endpoint. It demonstrated a 61% improvement in the risk of that endpoint over time, which was a substantial improvement, p-value that had many zeros. And all the secondary efficacy endpoints, including castration resistance delay, delay in PSA progression, delay in the next therapy, key response endpoints such as an undetectable PSA, complete responses and objective responses on imaging were all met. Importantly for patients, quality of life was maintained at a very high level. Most of the ARCHES patients, even though they had a high burden of disease, were largely asymptomatic. And most of these men remained asymptomatic in the about 14 and a half months follow-up that we have at this point. The toxicity profile is well known to urologists, medical oncologists all around the world. It's an FDA-approved and regulatory-approved therapy for castration-resistant disease. One of the questions that ARCHES will be addressing in the future is whether overall survival is improved by this delay, substantial delay in radiographic progression-free survival. At the time of this interim analysis, we only have 84 men who have died, which is very good news for our patients. But because of the substantial clinical benefit, we have offered these men treated with placebo crossover therapy to enzalutamide itself. And as you know, many men have access to these therapies commercially. Abiraterone, enzalutamide is available. And it will take several years to understand whether an overall survival benefit is observed. However, there are some practice-changing aspects to this study which I'd like to highlight. Some of the important subsets of patients in ARCHES permitted men who have already completed docetaxel chemotherapy. Nearly 20% of the ARCHES population had received docetaxel chemotherapy prior to randomization. And in that subset, there was a 50% further delay in progression-free survival over time. And this is the first study to show an added benefit to potent AR inhibition after docetaxel. So we don't have that data for some of the other potent AR inhibitors at this point. There will be a second phase 3 study of enzalutamide that will likely be presented in the coming year. It's called ENZA. This is an Australian study. It is powered for overall survival as the primary endpoint. And I think within the next year, we will likely have a choice of 3 or 4 potent systemic therapies, including docetaxel, for these men. Radiographic progression-free survival is a clinically meaningful endpoint, and delays in metastasis or death have been accepted by regulatory authorities, including the US FDA, for approval. And so we suspect that ARCHES will be part of a plan to approve enzalutamide in this earlier disease state. Overall survival is a noble goal, and most of the clinical trials that have demonstrated benefit have shown an overall survival benefit. ENZA will report on overall survival very shortly. And so based on these two studies, I suspect that enzalutamide will be a practice-changing alternative to abiraterone. The notable point that I'd like to make is that some men with high-volume disease are treated with docetaxel. And in ARCHES, men are further treated with enzalutamide with a substantial delay in progression, suggesting that for these high-volume men, ADT, docetaxel, and enzalutamide may be a reasonable standard of care to provide optimal outcomes. So we face this choice in the castration-resistant setting all the time. It's really based on comorbidities, costs, preferences. For example, enzalutamide may be contraindicated in men with seizure disorders, while abiraterone can be safely given in that setting. Enzalutamide may be preferred in men who have contraindications to prednisone or who have significant cardiovascular comorbidities where the mineralocorticoid excess caused by abiraterone may cause heart problems. In addition, enzalutamide is very well tolerated, particularly by younger men under the age of 75. But it's important whether you choose either of these drugs to emphasize blood pressure monitoring, exercise, staying fit and active, and following men closely. Enzalutamide has no real laboratory abnormalities, so many urologists do prefer this because it doesn't require as much monitoring.